everyone. I think we're going to make a start because we have quite a few brilliant speakers this morning and a lot to get through, but welcome everyone to this morning's webinar where we will be launching the new framework and addressing the three biggest killers regionally and locally. So just very quickly to go through the housekeeping, and I'll also just introduce myself. I'm Jilla Burgess-Allen and I'm the Director of Public Health in Stockport in Greater Manchester, and along with other GM and North Yorkshire and Humber colleagues with other partners have been involved in developing this new toolkit that we're going to share with you this morning. So the housekeeping, as I said, we've got quite a lot to get through. So I'm going to ask people if they have any questions to please put those in the chat if you can. And I'm hoping we'll have around 10 minutes at the end to answer those questions. The webinar is being recorded, and we'll also be able to share both the recording and the slides afterwards online. And if you do have any problems at all, please post those in the chat. If your question is fairly factual or straightforward and you want to specifically at one of the speakers in the chat, go ahead and do that, and we may be able to answer those directly in the chat to get through as many of the questions as possible. So, as you can see, there's been a number of partners who've been involved in the development of this toolkit. Greater Manchester Integrated Care Partnership, Humber and North Yorkshire Health and Care Partnership, and our other partners, ASH, the Alcohol Health Alliance and the Obesity Health Alliance. And I think it's really timely that we're getting together today to look at this work because, of course, the 10-year NHS plan was published just last week, and we can really clearly see that the government are committed to that shift from treatment to prevention. There's a lot in the plan that we can absolutely get behind, and then there are other areas where I'm sure you'll agree we might have liked the government to have gone further. There were, for example, those policy areas around alcohol and restricting advertising and minimum unit price for alcohol that were not ultimately in the plan, and those are areas that we can perhaps lobby up and push forward on. So today is an opportunity for us to share the fruits of the work that we've been doing collectively. And as I say, we're going to hear from a number of speakers who are going to take us through the framework and how we have developed it. So here's a quick look at the agenda. And if we move on to Peter, and 5 minutes on an introduction. Over to you.
Thanks very much, Jilla, and good morning, everybody. I'm Peter Roderick. I'm the Director of Public Health for the City of York. So you've heard from our over the Pennines contingent from Jilla, and I'm over in the Humber and North Yorkshire Integrated Care Board area, one of the two partners involved in developing this approach. So if we can have the next slide, please. I'm tasked today with just talking a little bit about the why we're talking about a coherent approach to three big killers. And I guess from one perspective, why a coherent approach, and you'll hear a bit more about that framework as we go through. But why those three big killers? Why are we concentrating on these three things? There are obviously a huge range of things that we think about within public health and population health, but why these three areas? We're thinking about smoking, we're thinking about unhealthy foods and the issues of obesity and overweight that they cause, and about alcohol, because they really do constitute such a burden of ill health and early death for our communities. The slide shows a little bit about the population prevalence of the use of these different factors: unhealthy food, smoking, and then drinking above the guidance, and shows a little bit about the amount of hospital admissions and the deaths which result from them. So we know these are the three leading causes of early death, and we know that tackling together is really important if we try to improve the public's health. Next slide, please. So we know that they're leading to worsening inequalities. We know we're on a journey as a nation around inequality and the gap in life expectancy, which isn't a positive one after decades of increasing life expectancy and a slight narrowing of the gap in the early 2000s. We are now starting to see life expectancy stall, and in some bits of our population it is reducing, and we are seeing the gap between the richest and the poorest, particularly in terms of both life expectancy, but also particularly healthy life expectancy, is increasing. And we know that tobacco is probably the #1 factor which is responsible for half that difference between the highest and lowest socio-demographic groups. But we know that alcohol causes a wider range of deaths in the most disadvantaged areas. A bit of a paradox, because actually the volume that's consumed is less, the alcohol harm paradox, but still we see the burden in terms of ill health fall on the most disadvantaged communities. And we know that the National Child Measurement Programme has shown for decades that children living in more disadvantaged backgrounds are more likely to be living with overweight and obesity. We have this ambition as a nation to halve the difference in life expectancy between the most and the least deprived. And it's categorical that without action on tobacco, alcohol, and obesity, we won't be able to do that. That is a mission that is entirely unachievable without action on these three things. Next slide, please. It's really important to make a distinction here and to think about why we're considering these things together. These three things obviously are different products. They're sold by different shops, perhaps. They are produced by different parts of the sort of the commercial sector. But what we do find is that rather than thinking about the individual and their consumption patterns of these things, lying behind the choices that we might feel we are making about what we eat or what we drink or whether we smoke or not are a set of wider systemic factors. And actually, as we go on this journey to talk about a coherent approach to these things, it's very important to start at the off by not focusing on the individual and the individual's choice or not to consume a certain product, but to think about the environments that these three things create for us, and how those environments are often stated against individuals that are actually trying to often do their best to live healthy lives, but they're not able to. And particularly thinking about the industries that lie behind tobacco, alcohol, and unhealthy food, and the tactics that they share commonly between them. This was, first of all, really seen with the tobacco industry, and we've known about the playbook that the industry have used to try and resist regulation for smoking, for cigarettes, for a number of years. But it's become very clear over the last 20 to 30 years that actually that's not singly applicable to just the tobacco industry. Other industries have started to pick up and run with the similar tactics. So there's tactics like the distortion of science and the distortion of messaging in order to make it seem less harmful, or to make their products seem less harmful, and to, in some ways, reduce the amount that individuals are turned off because of the health messages we know is very clear from the science. Thinking about the legal threats that they make against public health professionals and against public health regulation. Thinking about positioning themselves as part of the solution, often partnering with agencies to in some way increase the reputation that they have. Communicating through proxies and using particular groups, lobby groups that don't seem to have any links to them, but actually they do. And then corporate social responsibility. And we know that these industries are saturating our environment with harmful products. Next slide, please. So
just going to have to hurry you along a bit there, Peter. Apologies.
Of course, Jilla. So we know that these things are happening more in more deprived areas. We know they cluster and they compound the inequalities. That's really clear if you walk down through the high streets of some of our more deprived parts of the country. Next slide, if we can, please. But interestingly, we also know that the public are really in favour of action. So there's quite clear polling that suggests, actually counter to the narrative, that these products that we're talking about today, actually there's quite clear public support for action to protect people from the harmful effects of them, and action to regulate industries in order to protect us from their harmful effects. Next slide, please. So we have a bit of a playbook here. We know from the work that we've done on tackling tobacco that tobacco prevalence and smoking prevalence has declined, and it's declined very much in line with action that's been taken around regulating affordability, availability and promotion. So we have a little bit of a playbook for the way we might want to move this forward. So I'm going to hand back to Jilla for the next section of our meeting.
Thanks so much, Peter. And I'm going to hand over now to Dr. Robyn Burton, who is going to just talk us through some of the rationale for taking that coherent approach. Robyn.
Brilliant. Thank you ever so much. So moving on to the next slide. Yeah. So we talk about alcohol, tobacco and excess weight quite separately, and I think this is represented in our national statistics, which are often published separately, but we actually need to start thinking about these things together because the data shows that there is an overlap of these risk factors. So around a quarter of adults have more than one risk out of excess weight, drinking and smoking, and this is equivalent to around 10 million adults. So that's about 5.6 million adults who both drink above the CMO guidelines and have excess weight, about 2.5 million who have excess weight and also smoke, and about 0.6 who drink above CMO guidelines and also smoke. So next slide, please. But we also need to think about how these things cluster together. So the data are really useful to show us the prevalence, but actually we also want to know how they cluster. So in the top bar there, or top box there, we have alcohol and smoking, and you can see that this shows that drinkers are 2.68 times more likely to also be smoking. We also got some gambling data in this, so drinkers are also 2.66 times more likely to be gamblers. And then if we look at socio-demographic patterns, we can see that the odds of 2 or more risks are highest among people aged 45 to 64. They increase with increasing deprivation, whether we look at IMD quintile, qualification or unemployment, and the associations are stronger in men than they are women. Next slide. So this data comes from a systematic review and meta-analysis we published back in 2023, and this aimed to look at the clinical consequences of multiple risks. So not just if you only smoke or only drink, but actually if you smoke and drink, what does this mean for your clinical outcomes? So this analysis has about 138,000 adults in it, and we can see here in the graph you have your alcohol risk, you have your smoking risk, and then you have the interaction, or this is essentially what your risk is if you both smoke and drink. And this can be very simply summarised as the combined effect of smoking and alcohol on head and neck cancers is 3.8 times greater than the additive effect of each exposure on its own. So the risk is not simply alcohol risk plus your smoking risk, but it actually multiplies and is far more risky doing these two things than if you do either of them on their own. Next slide. So this is again the same principle, although this time the outcome is liver disease and we're looking at excess weight and alcohol. So this comes from 2.6 million adults this time. And again, we can see that you have your excess weight risk, you have your alcohol risk, and then you have the interaction, all those two risks combined. And in this instance, the combined effect of both alcohol and excess weight on liver disease is 1.6 times greater than the additive effect of each exposure on its own. So there's a real synergistic risk here. Now, I've picked these two outcomes because they're the two with the biggest synergies, but I do encourage everyone to go and have a look at that paper, and please do email me with any questions or any questions you may have today, because we look at other risks, including cardiovascular disease, neurodegenerative disease, and actually even when risks aren't synergistic, the joint risks are really large. So the data show that these things overlap. They are an issue for the most marginalised in society, and it has a really important clinical outcome. So that, from a kind of data and epidemiological perspective, really demonstrates that we need to be thinking about these three risks together. And I'll stop there because we only have 5 minutes. Thanks.
Amazing. Thanks so much, Robyn, and some fascinating research there. And I can see from the chat lots and lots of interest in that. I'm just going to very quickly give the local authority perspective. It's not an easy time for us to argue for those upstream approaches, given the financial constraints that we're working within, but the evidence is so strong in terms of the longer term impact of this work and situated in local government. Obviously, we work really closely and know our communities well. We know that there is public support for many of these approaches, and we have access to many of those policy levers, those close relationships with our colleagues in planning, licensing, trading standards departments. And for us in Greater Manchester, it's been really important to build those relationships, but also to build that kind of collective momentum, both across the 10 local authorities in Greater Manchester, but also with our combined authority. And I'm sure it's the same elsewhere. And really, we can generate that collective momentum to go sometimes further than central government. And the next slide gives an example of that in Liverpool, where they declared they were going to go smoke free before the national legislation has come in, and we're already starting to see really positive results from that. Later in the webinar, we'll hear some other amazing case studies of local areas that have really progressed with some of these policy approaches and the impact they're starting to have. I'm going to pass over now to Nigel, who is going to give us the perspective from the ICB.
Brilliant. Thank you very much, Jilla. My name's Nigel Wells. I'm the Medical Director of Humber and North Yorkshire ICB, but I'm also a family doctor in North Yorkshire. And it's really interesting that one of the pleasures of being a family doctor is seeing generations grow up in the communities we serve, but what some would call cradle to grave care. But it's also very distressing to see and witness generational poor health play out over and over again. And I remember one family vividly that sort of brings Peter and Robyn's points to play for me. Mikey Senior was a 60-pack a year smoker, lost his job, his legs, and his life in his late 60s. His son, Mikey Jr., unfortunately added alcohol to cigarettes, drank so much cider that he diluted himself, got cognitive impairment, and died in his 40s from oral cancer. And now Mikey Jr.'s son, who doesn't smoke, struggles with drugs, poor nutrition, severe mental health issues in his early 20s. And this family, like many others, have been let down by our inability to address the root causes, those shaped by the social and commercial determinants of health. And that's why this work and what we're outlining today really, really matters. As Peter said, these are not isolated personal behaviours, but symptoms of deeper structural issues that have let generations down. So for us in the NHS, we must understand that. We know there's a lot of uncertainty at the minute. The health and care landscape is evolving rapidly, but this also brings us opportunities to innovate and a space for leadership. And the NHS long-term plan and the 10-year strategy both emphasise prevention, and ICBs are uniquely positioned to make this real at scale. And we must move from reactive treatment to proactive prevention, especially in our neighbourhoods where the burdens are greatest. And you might have noticed that in the 10-year plan that neighbourhood health is a powerful opportunity, and it's talked about that. It's about delivering care closer to home, improving access and outcomes and empowering communities. But we must make sure that prevention is embedded at this level as well. ICBs can only do this when they work in partnership, and they need to partner with public health, primary care and local government to deliver these coherent and place-based strategies. And also for us in Humber and North Yorkshire, we have got some new mayoral combined authorities, which will become powerful partners like those on the other side of the Pennines. Because they bring democratic legitimacy and control over those key levers. So really in Humber and North Yorkshire, our centre of excellence for tobacco is expanding to include obesity and alcohol. And hopefully this reflects the benefits of a coherent and cross risk factor approach. So I'll hand back now. Thank you.
Thanks so much. I'm going to hand over now to Caroline to tell us a bit about how the toolkit has been developed.
Thanks, Jilla. I'm Caroline Cerny. I'm Deputy Chief Executive at Action on Smoking and Health. But previous to my ASH role, I worked at the Obesity Health Alliance, and that kind of explains a bit of the history for this project. So a couple of years ago, ASH, the Obesity Health Alliance and the Alcohol Health Alliance started to work together a lot more closely to think about what would a coherent approach at a national level look like. So those of you who worked in tobacco will be familiar with the Empower framework, and we use that as a bit of a kind of a starting point to understand the kind of the policies that have worked really well in tobacco. What do they look like? How do they translate across for unhealthy food and drink, and also for alcohol? And we started to map what was happening at a national level and came up with a framework for how we think the government could learn from progress in tobacco on unhealthy food and drink and alcohol. And some of you may be familiar with our report we launched about 18 months ago called Holding Us Back, which sets out the framework. While we wait for national government to take action on some of these areas, we started to talk to colleagues in GM and Humber and North Yorkshire about what can be done at a super-regional and a local level, and how can we turn that framework into something that could be meaningful for regions to take action where they can. So that's how this kind of conversation came about. And I'll hand over to Elaine to talk more about how we actually went about developing the approach.
Great, thanks ever so much, Caroline. Yeah, so hello everyone, I'm Elaine. I'm a public health registrar. I'm currently based at ASH, and I've had the great pleasure of working on this project with colleagues across Greater Manchester and Humber and North Yorkshire over the last few months. So I'm just going to give a little bit of background and detail on the toolkit framework that we've developed together and that we're launching today. So as Caroline's just laid out, the work we've been doing responds to a need to develop a more coherent approach to the three biggest killers on a regional and local level. And the result of that work is an adapted framework from the Holding Us Back framework that Caroline's just talked about, and a toolkit to support areas in implementing the approach locally. So we recognise that a lot of this work is happening already. So really it's about bringing it all together, sharing best practice, and trying to sort of support areas to be a bit more strategic about it. So you can see the framework on the right here, and I'll go into a little bit more detail over the next few slides about what's in it. So the framework sets out that a comprehensive strategy to tackle the three biggest killers should be underpinned by 4 key enablers. So through the strategy, we should be thinking about how we're tackling inequalities, as we've had set out. We know that industry often targets the most disadvantaged, and that the worst commercial environments often cluster in the most deprived areas. So any strategic response should respond directly to that. And we obviously need to ensure that funding is there for prevention, and that we're able to actually resource this work as well as we should be. We need to think about how we're managing the influence of industry as well. So that's both in terms of their influence over local policy development and how they're actually kind of getting into the room or not, and also how they try to go about shaping social norms. For example, how we know the alcohol industry does their best to get into schools to fund education programs on alcohol, for example. So how are we putting in place governance to stop that kind of thing happening? And then also how we're mobilising our communities. So thinking about ensuring the voices of those who are affected most by harmful products are helping us to shape policy locally. And we're going to hear a bit later from Jess from Greater Manchester, who's going to talk about a case study of how that's been done to great effect on the issue of childhood obesity there. So within the framework, we've set out 5 high impact areas, and they've been inspired by what we know works for tobacco, but adapted and applied to alcohol and unhealthy food and drink with that regional and local lens. So there's much more detail on all of these within the toolkit, and you'll find lots of evidence-based examples there and case studies, but I'm just going to run through them quickly on a very high level here. So the first high impact action area is to regulate advertising. So this could be done, for example, through banning advertising for high fat, salt, and sugar foods and alcohol on council property, transport networks, those sorts of things. We're going to hear a bit later from York on how that's been done really well there. Then the second area is around how we can shape the use of harmful products and think about the commercial environments that residents are living in. So a lot of this is around how we're using local planning and licensing powers. So that might involve actions such as restricting new hot food takeaways near schools. We're going to hear from Hull as a case study on that later on. Or, for example, how areas have been using the alcohol harms licensing matrix to take into account the harm of alcohol when making licensing decisions. And there's a case study in the toolkit on how that's been done in Bury and Bolton. Then the third area is about how we're influencing the price of harmful products, but also the affordability of healthy foods, for example, locally. So we might be doing this through, as we've heard a bit about advocating upwards on things like minimum unit pricing for alcohol, but also how we might make healthy food more affordable locally or more accessible, such as through auto-enrolment for free school meals or enhancing the free school meal offer to widen access, as has been done in Stockport. And again, you can find more on that in our case studies in the toolkit on the website. And then the fourth high impact action area is thinking about how we're communicating health messages. So that might be through kind of regional mass media campaigns, or it could be more local work, such as working with communities to spread evidence-based messages about alcohol. Again, another case study you can find in the toolkit is how Wigan have used the Communities in Charge of Alcohol initiative to do just that. And then finally, we need to make sure that we've got in place treatment services to support those people who've already been affected by harmful products. And in this area, we can think about how we can be a bit more comprehensive about this. So again, we've got a great example from Oldham in the toolkit where they've woven alcohol brief interventions through both weight management and smoking cessation work. So that's a bit of a kind of rundown on what's in the framework, and this tells you a bit about what's actually in the toolkit that you can find on our website from today. So there's a main toolkit document. You can see the front cover of it on the right there, and within that there's the evidence base for all of this, a kind of narrative argument, and also a step-by-step guide to help you develop your own approach. And then you'll also find a Making the Case slide deck, which you can adapt and use locally. We've also got an asset and deficit mapping template to support you in understanding what's working really well in your local area and where there might be opportunity to do a bit more. There's an asset and and then a stakeholder mapping template to help you understand your system better. And we've also got a whole range of different case studies to help bring it all to life. And those really focus on the sort of practical how-to of these different initiatives and policies, which I think can really help when you're trying to implement something locally to sort of see what challenges other people have come up against and how they've overcome them. So that's all from me, and I'll go back to Jilla now.
Oh, thank you so much, Elaine. And yeah, we're now going to move on to hear in a little bit more detail about some of those case studies. We've got 3 to go through with you this morning. And the first is from Jess in Greater Manchester.
Hello, sorry. Hi, everybody. If you just want to go on to the next slide. Thank you. So just to start off by saying Greater Manchester, like many areas across the UK and around the world, is facing a growing challenge in rising rates of overweight and obesity. And this issue disproportionately affects our most disadvantaged residents, with children and young people rising levels particularly concerning. So in response, NHS Greater Manchester, in partnership with our 10 local authorities, launched a large-scale city region public consultation. So the aim was really to explore residents' perspectives on the real drivers behind childhood obesity and raise awareness of its continued impact. So in the end of 2023, start of 24, we launched an 8-week digital campaign and a series of community engagement to help promote the survey. Our promotional adverts were co-designed with key stakeholders, including the Voices of Lived Experience, public health colleagues, our GM Food Security Action Network, community partners and those involved in weight management services. And we also worked closely with community groups to deliver focus groups across our 10 local authority areas, hear from seldom heard communities and really provide an offline method for answering the survey. I'm hopefully on the next slide going to play you a quick video for exactly what we delivered. This is where it might all go wrong.
A lot of parents seem to excuse overfeeding children.
Some people seem to have a lot to say on childhood obesity.
That's child cruelty in my book.
I think the parents are to blame.
These things start at home.
But it's not helping things in Greater Manchester, is it? So when the NHS launched a survey to see what was really behind the crisis, we needed to invite a different kind of voice into the conversation.
The highest level of obesity since records began.
It was time to disrupt the debate. We showed that every factor in childhood obesity had a deeper story to tell.
Pizza and pizza and pizza. It's honestly all she'll eat.
We showed the struggles.
Look, I'm not loving how much junk food they eat, but it's hard when they see it everywhere.
And the frustrations.
Seriously though, how can I get my daughter outdoors when her friends are always online?
Every execution offered an honest perspective to invite the public to share theirs. And it did get a bit spicy at times. We turned takeaway culture into a talking point. We used an iconic fast food item to generate debate. The campaign gave Greater Manchester's diverse communities a chance to share their voice. And they did. The results of this survey are now informing conversations far and wide. So if you want the real picture of childhood obesity, you don't shut the public out. You let them weigh in.
Thanks for that. So, in terms of
democracy depends on a free press. Please support our.
In terms of what did we find then? So unsurprisingly, the campaign drove an influx of diverse and impassioned comments, capturing around 10,000 GM voices through survey entries or through dialogue across social media. The survey actually took around 12 to 16 minutes to complete, which I think shows the level of engagement from residents on this topic. 79% said tackling childhood obesity should be a top or high priority for local councils or health services, but most people were unaware of what's already being delivered to address it. When asked about root causes, access to unhealthy food came out on top, with the low cost of junk food, too much screen time, junk food advertising, and confusion over what food is actually healthy high on the list. The key takeaway was a clear message from the Greater Manchester public, and that was that they cared deeply about childhood obesity and changing the environments that they see fuel it. They also want to see more visible and coordinated action from us to tackle it. Next slide, please. Just to finish off in terms of some of the key lessons that we've learned through our process of community mobilisation in Greater Manchester, wanted to start off by saying, obviously, childhood obesity is a very complex and sensitive issue. So for us, it was really important to get the right people in the room from the start of the programme. So the Voices of Lived Experience was central to our campaign creation and development, and key partners who were really going to help us to drive the survey forward and make sure that it lands locally. Secondly, I'd say if you're going to go to the public with questions, really do expect them to answer, and you might not always like what they have to say. So as part of this, we did develop a series of responses for the NHS and local authorities to respond to residents' concerns. I think timing really matters. So thinking about how this lands and what else is going on locally can really help. So for some of our partners, the timescales of November and December wasn't an ideal time to run this campaign. The focus was very much on Christmas festivities and warm homes. However, we found that it actually gave us a captive audience more likely to be taking some time off work and really helped to drive up those survey responses. I think we really thought about the different audience for our results after the survey. So we thought about splitting up the data to provide localized versions of the summary to make sure that it made sense to what does this mean for Tameside, what does this mean for Rochdale, instead of just taking that GM-wide approach. We also created the short snippet videos like the ones that I've just shown you, and some summary decks for different boards and audiences who might be a bit more time strapped and don't really want to read through a 70-page thematic analysis. And finally, I just want to close off by saying I think it's really important that we return to our audiences to tell them how their contributions are helping to change things, shape or achieve some of our ambitions around childhood obesity. So their voices have been really instrumental in our discussions on pan-GM, HFSS, food and drink advertising restrictions, for developing the direction of our GM Food Programme Board and influencing our obesity pathways at the NHS. And we really intend to go back out and share how this is developing with them later this year. Thank you.
Thank you, Jess. And I can see lots of love for the Real Picture campaign in the chat and from the audience. And actually that campaign recently won an international award as well. So well done to everyone involved in that. The next case study we're going to hear from is from Philip in York. Over to you, Phil.
Thanks. Morning, everybody. I'm Phil Truby, Public Health Specialist at City of York Council. I've got a next slide, please. So the headline is in May last year in York, we became the 14th local authority who was able to implement a HFSS policy, high fat, salt and sugar restrictions policy. That was kind of the driving impetus for it, but the policy also includes a wide range of products within the commercial determinants of health, and I'll go on to explain those in a second. Next slide, please. So the policy covers both advertising and sponsorship across all of the local authorities' property and public estate. So that includes any contracts that we go forth to let. The policy is worded in such a way that it details types of organisations, products and services that are prevented from advertising. But at present, it doesn't specifically name organisations or products. So there's the provision there to do that if we deem it necessary in the future. But for now, it focuses on broad categories of products and services. And you can see that those are listed there on the right. So some of the ones that took a lot of discussion and debate were around vaping products, given that we, through our local authority Stop Smoking Service, provide vaping products. So we had a long think about the pros and cons of that. Nicotine pouches, we've been recently added to our policy. And then other things of note on there, obviously the HFSS products, loans and speculative financial products as well. We were keen to get those in there. And yeah, alcohol products, and the worded on that is around manufacturers of alcohol products. So we get into a bit of a grey area when we're talking about zero alcohol products and whether that's a solely alcohol producing company or if it's a solely alcohol zero company. So there's a bit of nuance in some of the wording, but I've put the link into the policy there. It is published online, and I think that's a real benefit because actually it's a live document. It's something that we can be referencing in any of our contracts that are let, and that we can take it through a process to review, modify and change. So as I mentioned previously, adding nicotine pouches to that was a process that we took through with our policy colleagues and through our executive member for health, and we're able to add that in a fairly timely fashion. Next slide, please. So how we got there? Sorry, the text is a bit small on this, but it was a long process. It commenced pre-pandemic. Obviously, then the pandemic hit, and that did kind of halt things for a couple of years. The impetus for this being picked back up again was the reletting of the bus stop advertising contract. I don't know how much people know about bus stop advertising contracts. It wasn't something that had particularly crossed my world before getting involved in this, but they're usually a really, really long duration. Ours was previously 20 years. So obviously we wanted to get in there and have a policy in place if a new contract was going to be let for such a long duration. I was really lucky that we received support through the Association of Directors of Public Health in Yorkshire and Humber from Sustain, and Fran at Sustain was absolutely pivotal in helping us get this policy across the line. She really provided some great support. We built on the experience of those who've gone before us. We had really great leadership within our public health team, and we were able to work across the whole organisation. It was a really positive approach. Next slide, please.
Just going to have to hurry you along there, please, Phil.
No problems. I guess there was a few challenges that we faced along the way. Director level buy-in was one of those. Elected members was another. It could be a challenging route through. However, once we had the policy formed and once we had those sort of conversations bridged, actually the implementation was a fairly straightforward thing to do. Next slide, please. We don't have an abundance of digital screens, although our main revenue is from bus stop advertising. We're in the process of transferring across from one provider to another, which is involving the removal of over 100 bus stops and reinstallation of new ones. So I'm now involved in bus stop advertising contract monitoring meetings, which I didn't think I was going to be doing as a public health specialist, but it's the right thing to do. And ultimately, we're starting to see the fruits of this as the new contracts go live. Next slide, please. This is my final slide. I guess the next steps for us in York are we don't directly manage the transport network, so having conversations with our bus stop, with our bus providers, the main one being First, and with our main train station, which is managed by LNER. So influencing those conversations and trying to get an adoption of a policy that's in alignment with our own. I think that's me. Thank you very much.
Fantastic. Thank you, Phil. Really interesting to hear about that work. Our final case study is from Hull, and I'm going to hand over to Joanne.
Thank you, Jilla. So good morning, everybody. I'm Jo Arro, and I'm a Commissioning and Service Development Manager at Hull City Council in Public Health. And I'm going to talk about Hull's hot food takeaway policy this morning. I'm just going to set the scene really quickly. So why really is excess weight an issue in Hull, and then just quickly going to talk a bit around the whole systems approach and how the hot food takeaway policy fits into that whole system. So this is just one of the policies or levers that we're using in Hull to tackle excess weight. So the whole picture, about 70% of adults in Hull are living with excess weight, and that's compared to about 64% in England. And 26.4% of reception children in Hull are living with excess weight, and that's higher than the England average. And 42% of Year 6 children in Hull are living with excess weight, and again, that's higher than the England average. Next slide, please. So I really love this diagram, and it explains a little bit around the whole systems approach. So in Hull, I'm sure some of you have also adopted the whole systems approach. It's around looking at taking a whole systems approach to excess weight, and it looks at all the different cogs and all the different reasons and all the different influences that can influence excess weight. And then you look at all those different levers and track them back and unpick them and work out what levers sit within the local authority, how we can do something about this, you know, what's in our power to do. And also sometimes it's a bit about going with where the energy is. So sometimes you'll push in a closed door and sometimes you'll push in an open door, and it's a bit around, you know, what can you do around this? So just for example here, if you think about the food element of this, you've got things such as what food's available to buy in the shops, what can I afford? Do I have the skills and knowledge to cook the food? Can I afford the energy to cook the food? So it's quite complex, and this is where the whole system really works well, because it gives you a chance to unpick all of these issues and look to tackle some of these issues separately. And if you think about all the things that influence and impact on our decisions, you start to see how multifaceted it is. So making, for example, making healthier foods cheaper, more accessible, providing cooking under budget sessions to upskill, helping those on lower incomes to access things like the Healthy Start schemes. So some of them you can start to look at what you can put in place to try and change some of these levers and impact on them. So next slide, please. So this is our whole system's healthy weight map in Hull, and as a system, so quite a lot of us got together who all have an influence on this area, and we mapped of everything that we could impact on excess weight. And that's, you can see in there's lots of things like early years education in schools, active travel, knowledge and experience of professionals. And the bit that I just want to focus on there is a food environment, which you can see highlighted in red. And one of those things was around in Hull at the time. We were looking at sort of 2016 when we did some of this mapping, and the hot food takeaway proliferation in Hull was really high. I think we were something like third in the country per population head, and it's something that we then decided to work with. Next slide, please. With our planning department. So we took this approach as part of the whole system to work with our planning department and included some policies into our local plan, which was adopted in 2016, to restrict the number of new hot food takeaways. So it's not about closing takeaways down, it's about restricting that proliferation. So these are the policies that we included, the first policy was around limiting the number of new takeaways that would be supported within a local or neighbourhood centre. So you can see that development to accommodate hot food takeaways will not be supported in local or neighbourhood areas where a threshold of 20% in all units have already been reached. And then the second policy was to limit new hot food takeaways within 400 metres of a secondary school, sixth form college or playing field. And you can see those policies in there. Development to accommodate hot food takeaways will not normally be supported within 400 metres of a secondary school or sixth form college or playing fields. And what we did then, because we got it in quite early, it gave us a chance to look at the evaluation. Is this working? And in 2016, Hull had about 302 hot food takeaways in the city. And we reassessed it in 2023, 6 years later, and it had 259. So that's about 43 less hot food takeaways. So you can see the impact that that's had in Hull, which is amazing. So we're really thrilled with that. And what we found, which is really interesting, is that as the policy got out there and people started to find out that they wouldn't get their hot food takeaways accepted, they stopped applying if the policy applied. They stopped actually applying for hot food takeaways if they felt the policy would apply. So there's been a reduction just in the application of new hot food takeaways in the city. Next slide, please. So as anything, it always comes with challenges, and I just want to mention that on the next step. So some of the challenges, for example, you're always going to get challenges around from developers or fast food outlet chains around this, and unfortunately some of them are quite well funded, so that can bring some issues. I think some of the levers in planning are quite a blunt tool. So for example, are all hot food takeaways selling high fat, salt, sugar food? You know, there's some healthy ones in there you are restricting. They tend to be high fat, salt, sugar foods, but it covers a blanket of hot food takeaways. And then the other side of the argument is around balancing the outlets selling healthier foods. So it's okay restricting hot food takeaways, but then there isn't the tool in there to create more healthy, for example, fruit and veg shops or shops that are selling healthier foods within that. And then sort of going forward, there's a new national policy planning framework which was released in December 2024. And this has gone slightly further, that it includes refusing applications for hot food takeaways and fast food outlets within walking distance of schools and other places young people meet, unless the location is designated town centre, or locations where there is evidence that a concentration of such uses is having an adverse impact on local health population or antisocial behaviour. So we're currently refreshing our local plan, and we're hoping to add this new policy into our new local plan. I think some of the thing is, what's the definition of a fast food outlet? And that's sort of some of the challenges. And that's it. Thank you.
It's amazing to see what impact that policy has had since it was introduced. Okay, so we're reaching the end of this morning's webinar, and before we wrap things up, I'm going to open it up for Q&A now, and thank you everyone for the questions, but also the shared good practice and the information and the ideas that I can see coming in to the chat. So there are a few questions in the chat. I think there's one from Emma around the role of family hubs. Do any of the speakers want to respond to that one? There's also one from Charlie around whether smoking prevalence reductions have impacted on health. And I'll probably first come to Caroline, if that's okay, to answer that one from Ash.
So yeah, I mean, it's kind of hard to make a direct kind of causal link, but there's quite a long, obviously, lag time between smoking prevalence reductions and then the impact on health. So I off the top of my head, I couldn't say that I could point you to something that shows that direct link. And of course, as we've kind of been exploring today, these kind of risk factors kind of overlap in the population, so there's a kind of quite a complex picture in terms of the impact on health.
Great, thanks, Caroline. Do any of the speakers want to respond to the family hubs question? Go ahead, Peter.
Thanks, Jill. I picked that one up. So I think there's questions in the chat about the family hubs approach and announcements last week, as well as some questions about education and working with schools. And I think there's definitely something within this framework which is really important, and you'll have seen it on the side around, I guess, the promotion of the messaging and getting the message right. And I guess what I probably we're trying to encourage through this framework is to make sure we're not relying purely on putting messages from a kind of a state to the individual and expecting that to enact the change. So whilst education is very important, and whilst our family hubs will be great places to engage with communities and individuals, that alone doesn't work. And it may not be the 100% most effective bit. It actually might be that some of the regulatory stuff and the removing of industry influence over time will lead to a higher impact. But all of the bits are going to need to take place. A family hub, a Sure Start Centre, whatever we will call it going forward, will be a fantastic place to bring some of that together. What we do have to do is make sure the existing reaches of industry into, for instance, our schools are slowly eliminated. And there are some good examples of where schools are using materials which are industry funded. We've got to make sure we remove that. That's probably the first step. And very important from the education and family hub perspective.
Brilliant, thank you. And Nigel, do you also want to come in on that one?
Yeah, I was just going to say that the opportunity for neighbourhood health really steps into that space that Peter talks about. Now, I wouldn't want people to think that we have to wait to be told that we need to do these things for certain populations or certain communities that we know about or we want to step into. So I think that's one of the opportunities for cross-sector working in the ICBs is to think about how we embed that work that Peter's talking about, not wait for people to tell us that we need to do it.
Great, thank you. I can see there's also a question in the chat from Joanne about the role of secondary care. Is that one that anyone would like to pick up? I wonder if there are any examples where we've been successful in working, for example, with hospital settings and their catering, or their cafe provision, or vending machines, that kind of thing, or anything else anyone wants to highlight? I'll give you a moment to think about that one. Oh, Nigel, do you want to come in? You got there first.
Yeah, I don't know much. I don't know particularly about maybe more the inward facing bits, but I would just say, as a clinician, I think we've got to recognise that, you know, I know everybody talks about it, but every contact does count, and we do need to make sure that our secondary care colleagues know what's available and link it up to what's available in communities as well. So that's how we can help, but it's more linking the clinical colleagues together, I think, around that.
Great. And Peter?
Thanks for that. I think there's loads of hospitals can do. There's a whole framework around health promoting hospitals, which I know many are trying to embed. I think if there's one thing, the single one thing that would do the most in terms of the things we talked about, it is successfully making sure that hospitals are treating everyone who is dependent on tobacco, getting them onto NRT and getting them out the door when they leave into a community stop smoking service, because that's so well evidence-based from Ottawa, etc. We're trying to implement it across the whole NHS. It's a little patchy in some areas, working very well. If all areas were to get up to full speed on that, that would have a huge impact on smoking rates and save lots of lives.
Brilliant, thank you. There were a couple of questions, Joe, in the chat around your policy work, and particularly around what about healthy takeaways, and would there be any exceptions? I don't know, I know you covered that somewhat in your presentation. Anything more you want to say on that?
Yeah, it's a good question. I think, as I mentioned, it is quite a blunt tool, but it is a tool nevertheless. What I would like to see, and we were consulted on the new national policy framework, and I would have liked to have seen a bit more around how it could be used to promote the healthier food environment. Maybe that'll come in. That'll be great if it did. Or I mean, there are ways of doing that, but I think that maybe some of that would sit with planning. Some of that could sit with, for example, looking at business rates and reducing business rates around those outlets that sell healthier food options. There are some options out there, but yeah, it's quite a complex area.
Great. Okay. Well, we are fast approaching 11 a.m. So I am going to wrap up the webinar now. The toolkit goes live on ASH's website today. So please go and have a look at it in more detail. But also, please do come forward with any further case studies you may have. I've seen some of you have been sharing things in the chat. We welcome more case studies and really keen to build up that bank of good practice. And in Greater Manchester and in Humber and North Yorkshire, we are committed to taking forward this work in our places. I hope you will do likewise. And thank you so much for joining us this morning. Bye-bye.